In chronic invasive fungal rhinosinusitis involving the sphenoid and ethmoid sinuses, the likelihood and sequence of cranial nerve and optic nerve involvement differ between Mucor and Aspergillus species due to their unique invasive characteristics. Mucor species exhibit aggressive angioinvasion, invading blood vessels to cause thrombosis, ischemia, and necrosis. This facilitates rapid spread to the orbital apex and optic nerve sheath, often through necrotic tissue and bone. In comparison, Aspergillus is less angioinvasive, spreading more slowly and following tissue planes. Optic nerve involvement occurs later in the disease due to a more localized and indolent course. Mucor shows rapid, aggressive growth and a preference for vascular necrosis, invading deeper structures like the optic nerve early in the disease course. Aspergillus, on the other hand, progresses with granulomatous inflammation, typically requiring extensive local disease or bone erosion to involve the optic nerve. Mucor infections are common in severely immunocompromised individuals, such as those with uncontrolled diabetes or profound neutropenia. These altered immune states enable rapid progression into the orbit and optic nerve. In contrast, Aspergillus is more common in immunocompetent or mildly immunosuppressed hosts, where the immune system slows disease progression. Mucor invades bone directly, including the thin walls of the sphenoid sinus, to reach the optic nerve. It can also spread through the superior orbital fissure and orbital apex, resulting in early cranial nerve involvement. Aspergillus tends to remain localized to the sinus cavity and affects the orbit through chronic erosion of the bone, often sparing cranial nerves until the disease is advanced. In most cases of sphenoid and ethmoid invasive fungal rhinosinusitis, the sequence of cranial nerve involvement follows a distinct pattern. For Mucor, the involvement typically progresses as cranial nerve 2, 3, 4, 6, V1/V2, reflecting its rapid spread to the optic nerve and orbital apex early. For Aspergillus, the sequence is often cranial nerve 3, 4, 6, 2, V1/V2, highlighting its predilection for initially involving the orbital motor nerves before affecting the optic nerve. This distinction in cranial nerve involvement provides a valuable diagnostic clue in differentiating between Mucor and Aspergillus infections. Mucor's aggressive angioinvasion, rapid growth, and necrosis-driven spread make optic and cranial nerve involvement more likely early in the disease. Conversely, Aspergillus spreads slowly and chronically, leading to delayed cranial nerve and optic nerve involvement unless the infection becomes extensive. Understanding these differences is critical for timely diagnosis and management of invasive fungal rhinosinusitis, particularly in distinguishing between these two pathogens in clinical practice.